Now, this next section here, we're going to talk about the indications for actually doing the x-rays, and we're going to talk about the variety of x-rays that we may be called to perform. Okay, so we're going to talk about these areas here, and then after this section, we'll take a quick break. Okay, and then we'll have some interactive polling questions afterwards. Okay. All right, so what are some indications for abdominal pelvic radiographs? So some of the indications that we see are abdominal pain, distension, suspected foreign body, trauma to the abdomen, potential renal calculus, or to even determine the location of a device that a medical professional places. Okay, so these are some of the things that we are seeing as reasons for getting these x-rays done. Now, an acute abdominal series is a combination of exams, one of them being the supine abdomen x-ray. Okay, so a flat x-ray of a patient. Usually we want to see the kidneys, ureters, bladder on this image. Okay, some other types of procedures we may see in an acute abdominal series is an upright picture to see air fluid levels. Okay, so with air fluid levels, we potentially need either a upright standing abdominal x-ray, or potentially, a left lateral decubitus x-ray. Okay. In some facilities, an acute abdominal series also includes a PA chest. Okay. And the reason that chest film is included is certain pathologies present as abdominal pain. So pneumonia, pleural effusions, those sort of pathologies will seem like the patient is having abdominal pain. So that is why a chest film is also included, okay, because it can mimic some abdominal pathology. So we want to check the chest area as well, okay. So an abdominal series versus acute abdominal series, it's easy errors to make when we're looking at those things. Again, we're looking for some of those things such as, air fluid levels, perforations of the abdomen, obstructions, things like that are what we can see in these x-rays. Now, the first x-ray we'll talk about is that PA erect chest x-ray. So the PA erect chest x-ray, we are going to try to do this at the wall bucky, 72-inch SID, all right? We'll try to use automatic exposure control to get the correct amount of technique to that patient, right? If we position properly, utilizing automatic exposure control, we give the least amount of dose to our patient that they need to get for that procedure. If you aren't using automatic exposure control, the technique can vary. 120 kVp is usually our standard here for kVp. It can vary anywhere from 4 to 8 mass for the average patient, more so if you have a hyperstenic patient, okay? Now the central ray, this is our bread and butter. We should know this, like the back of our hand. The central ray is placed at the level of T7, okay? That is where our crosshair will be aligned to, okay? So it'll be aligned mid-sagittally, right? And at the level of T7. How we teach this normally, we try to say, mid-sagittal plane, usually the spine is a good mid-sagittal structure. So we can, use that as our vertical crosshair. The inferior angle of the scapula can be utilized as a T7 cross-reference point, okay? So that's what we can use. And then we want to place shielding to our patients. Since we're not really anywhere near close to the gonadal area, we can potentially shield that area without being weary of getting the shield in our image. The evaluation criteria. So what we're looking at in the evaluation criteria is we're looking at the entire lung fields being visible on our projection. So we want to see from apex, which is the top, to costophrenic angle, which is at the bottom here. We need to see that to ensure that we have a good pH chest x-ray. No rotation. So no rotation, what we're looking at is here at the sternoclavicular joints. They should be equidistant from each other. We should see the trachea midline, so that's what we're seeing here. The scapula outside of the lung field, which means we rolled the patient's shoulders forward. We should see outlines of the heart, which we do here. We should see 10 posterior ribs above the diaphragm. So if we were to count here, we would have 10 posterior ribs above the diaphragm. That's how we would know we had a good inspiration. Okay. Now the AP erect abdominal x-rays. So when we're doing, we'll stay with the things that are done standing. So AP erect abdominal x-ray. So this is done at the wall bucky if the patient can stand. The SID is brought closer. So we're going to do the SID at 48 inches or so, 48 inches. Automatic exposure control, if we're going to use it, all detectors selected. If we're going to utilize manual technique, 75 kV to 30 to 50 mass is normal for an average size patient. And how we do this one is we place our central ray perpendicular to the image receptor, entering at 2 inches above the iliac crest. So we'll measure the iliac crest, and then we will place our center point 2 inches above it, okay? And we need to include the diaphragm for this projection. That's one of the most important portions of an abdominal erect x-ray, is to include the diaphragm, okay? We can probably shield this patient because the information that we are looking for is not here lower. It's more up here in this area. One of the quicker tips that we give our students, is that potentially this top light area or the top of the light field should be around the level of the axilla if you want to ensure that the diaphragm is on the image. Okay. And so what we're seeing, and this is our image here, the diaphragm must be shown. So we're seeing the diaphragm on both sides here. Okay. And the reason is we are looking for the pathology of pneumoperitoneum, which is air in the cavity here. Okay. So air rises. So if air is rising when we are standing, it would rise to the level of the diaphragm. So if we don't include the diaphragm, we wouldn't be able to diagnose a pneumoperitoneum. So we need to include the diaphragm. We have no rotation, right? It looks like there's no rotation because the obturator foramen look similar. The iliac wings look similar. This person probably has slight scoliosis. As you can see, it kind of curves here. Anatomy shouldn't be obscured. We shouldn't have anything that would obscure the anatomy. And then we would probably want to annotate on this projection. Somewhere we would put upright or something along those lines. Okay. Let's go to the next one, which is the supine. So the supine we're doing at the table, 48 inches, automatic exposure control. We're going to select the 3 detectors. If not, 70 to 75 kVp to 30 to 120 mass may be used. And that's dependent on the patient's size, right? Their thickness may be a little bit thicker, so we may have to increase our mass to get a good quality radiograph. And then our central ray is at the iliac crest. So we're going to feel for the hips here. We're going to feel for that iliac crest, and we're going to place our central ray at that point. Okay. And so for the supine abdominal x-ray, no rotation. The abdomen should be free from rotation because you can see symmetry in the ribs, the iliac crest, the obturator foramen. Annotations that it was supine should be placed somewhere, especially if you're doing an acute series. We shouldn't use shielding because we might obscure some areas here. Now, the entire diaphragm must be seen without motion. So that one is potentially different depending on the facility you work at. And so over the course of the 10 years I've been a radiologic technologist and the various clinics I've worked at, the various areas I've been, I always have to ask how places do their abdominal x-rays. Because I've been to some places that only the kidneys need to be seen. So if you see the kidneys, you're good, as long as you include the symphysis. I've been to some places where you have to include the diaphragm and the symphysis. I've been to some places that do a lengthwise lower portion, a crosswise upper portion. So it all varies dependent on the facility you're at on how they want these x-rays positioned. Okay. Now the AP decubitus, the left lateral decubitus. So this projection, guys, is used when our patient can't stand, but we need to see air fluid levels. So we would utilize a left lateral decube if our patient couldn't stand. So what we would have is we would have a 48 SID. We would have a horizontal beam. So the beam would actually not enter this point. It would be at 90 degrees and enter this point here. Okay. We would have a grid holder on the tabletop, or we would utilize the wall bucket, but we would have a horizontal beam. We would place it at the iliac crest, same area as the one before. And our images look like this. Okay. So here in these images, it's a little blurry, but this gets the gist of what we're looking for. The entire diaphragm should be seen, okay, without motion. No rotation, soft tissue gray tones. We should be marking the right side, right? Because the right side will be up in a left lateral decube, okay? And you can see here, there's that air that we were talking about in the peritoneal cavity, okay? So there's that air, all right? Now, one of the things that we need to note is usually the left lateral decube is the one that is specified. Now, right lateral decubes are not as used, especially when looking for air fluid levels or air in the abdomen. Reason being, if we were to flip this image and the right side is up, there's already air on the left side. So the left side would be up in a right lateral decube. So there's already air in that left side. So it would be harder to distinguish air versus other things. That's why we do a left lateral decube, because on the right side of the abdomen, the side that will be up, is the liver. And remember what we said about the liver. It's a homogeneous structure, so it will look similar. So we should be able to instantly pinpoint if anything looks different in that aspect when we have the right side up. Okay, so that's why we do a left lateral decube. The AP pelvis. So the AP pelvis is something that we can also do. 48-inch SID, table, automatic exposure control selected, 70 kV to 20 to 30 MAS. The central ray is perpendicular to the midpoint of the image receptor, midway between the level of the ASIS and the symphysis pubis. Okay. Some ways that you can determine where to place the central ray: if you feel for 2 inches inferior to the level of the ASIS, you probably are in the right spot. Okay, so that's one of the ways. the way that I usually tend to do this is I feel for the top of the crest, right? And then I put the light field slightly above where I feel the iliac crest to be. That means that the top of my light will now be at the very top of where the iliac crest is. So then any information below will also be captured. Okay, that makes it a little bit easier when performing this procedure. We also should of course have them dressed properly. This is just an image showcasing the positioning, but yes, they would be dressed with no belt, no zipper, because this area would be obscured by those artifacts. Finally, we should rotate the patient's feet. So we're going to rotate the patient's feet 15 to 20 degrees internal. Okay, so these are our feet here. They're looking like this. We want to rotate them so that they are pigeon-toed like this. Okay, and this is what we're seeing here. Okay, so we want to include the entire pelvis from the iliac crest to the ischial tuberosity. Okay, how we know there's no rotation? Okay, this area here is the obturator foramen. It looks similar to the other obturator foramen. The iliac wings, the iliac ala, they look similar. So that means there's no rotation. The sacrum's in the center. That means it's not rotated. The greater trochanter and profile. Okay, so when we rotate our feet in, we should not see any portion here. Normally, we can tell if we did not rotate the feet properly based on if we see the lesser trochanter in this area. Okay, so we're trying to see a true representation of the femur in this area. Okay, we want to see a true representation of this area here. Okay, so that's why we rotate the feet in. All right, and so comparison of equivalent dose. So the dosages, guys, for chest x-ray, 0.02 millisieverts, abdominal x-ray, 1.5 millisieverts, abdominal CT, 9 to 10 millisieverts. So you can see how an abdominal CT is much more radiation dose to our patients. So if we can diagnose our patient using an abdominal x-ray, it's probably better for them. But in any case, there again are some structures that we cannot identify readily without the use of a cross-sectional modality.